welcome everybody. Welcome to Ghana country, to the Health Equity Learning Lab Oz, which is called our Hello webinar. And I'd like to start by acknowledging that I am, and I think both our speakers are on the land of the Ghana people, and pay respects to their elders past, present and future, and also acknowledge their amazing resilience through the processes of colonisation. It's really good to see everybody here. I think in the year of the referendum, it's really important for us to focus on Aboriginal health as part of the big challenges we face in Australia in terms of health equity and making things much more equitable. Our two speakers I'll introduce as just before they speak, and our first speaker is David Scrimgeour, who is actually an adjunct associate professor of public health at this university at Adelaide. And he, perhaps most importantly though, he's got huge experience both in Australia and overseas as a general practitioner and public health physician, I think including training at Harvard, David. And he has worked a lot in the Western Desert region of Western Australia, Northern Territory and South Australia for a long time. And he's drawn on this experience to write a book called Remote as Ever, The Aboriginal Struggle for Autonomy in the Western Desert. And it's a very engaging read, David. I can't say I've read the whole thing, but I've dipped into it enough to see that it is very engaging. So he talks of his experience in working with Aboriginal community-controlled health organisations, including as well as the Homelands movement, which the two sort of social movements were very related. And I think it's going to give us an overview of the book and tell us a little bit, or draw a little bit on that experience of 40 years. So over to you, David.
Thanks, Fran. I'll just put up the slides. And perhaps Michael could, on our behalf, give an acknowledgement of country.
Yeah, thanks, David. Yeah, also I'd like to acknowledge that we are presenting on the lands of the Ghana people, pay our respects for Ghana elders past, present and emerging. We'd also like to acknowledge any elders who will be linking into the webinar today. Just considering the topic we're presenting about today, also would like to acknowledge all the Aboriginal and non-Indigenous people who've contributed to the development of the Aboriginal community control health sector, maintaining it and growing from strength to strength as we are today. Yeah, and also special acknowledgement and pay respects for those people who may have passed also. Thank you.
Thanks, Michael. So the structure today, very quickly, will be, I'll just make a couple of introductory comments, and then I'll talk a bit about the background and history of the Aboriginal community-controlled health organisational movement, and some points about why these services are as effective as they are, and then a bit about the government response to the ACCHO movement over the life of the movement. And then I'll hand over to Michael, who will build on some of those comments that we've had about why ACCHOs are effective, and then go on to talk about some of the challenges and opportunities before going on to give a summary and some final comments. And we do want to make sure we have time at the end for questions and discussion. So we'll try and limit the time we have to about 15 minutes each. And that should leave plenty of time for discussion at the end, which we do look forward to. So just the introductory comments I want to make. I mean, as Fran said, thanks for the plug, Fran. I mean, my book, Remote as Ever, it came out just late last year, so fairly new on the market, and is available in all good bookstores. So a shameless plug there, but it is about the the subtitle is The Aboriginal Struggle for Autonomy in the Western Desert, and the two components of that struggle for autonomy that I talk about are the two social movements that I just found myself involved in when I first got involved in Aboriginal health about 45 years ago in Central Australia. That was the Homelands movement, the movement of people moving back to reoccupy their country, and the Aboriginal community-controlled health service movement, where people were taking control of their own health service delivery. And I think both of these both of these social movements were a reflection of the desire of Aboriginal people to have more control over their own affairs. And of course, today we're just going to concentrate more on the ACCHOs, on the Aboriginal Community Controlled Health Service movement. But I just sort of, we're talking about in terms of health equity in this webinar. And in general, when we talk about health equity, we think of equity in health, access to healthcare, or in health outcomes. But I think it's also useful, particularly in the area of Indigenous affairs around the world, particularly in settler colonial contexts, to think of equity in terms of equity of agency, or equity of self-determination, of the ability of people to have control over their own affairs. Whether you think of that as a sort of a determinant of health equity in access and outcomes, or whether you see it as being important in itself. I think it is important to consider in Aboriginal health, and certainly that's a big part of what the Aboriginal Community Controlled Health Service movement is about. So the Aboriginal Community Controlled Health Services, or Aboriginal Community Controlled Health Organisations, both terms are acceptable. They're also just sometimes called Aboriginal Medical Services. They have a significant history going back 50 years or more now, but they really arose as a social movement from within the Aboriginal communities themselves throughout Australia, and particularly in the 60s and 70s, which was a time of a number of social movements. But this movement of Aboriginal activists agitating for greater self-determination for Aboriginal people, greater control of their own affairs, including taking control of service delivery in various areas, including health. This movement sort of gathered strength in the late 60s and 70s, and the Aboriginal Community Controlled Health Service movement usually dates itself from the opening of the Aboriginal Medical Service in Redfern, in the inner city of Sydney, with a large Aboriginal population in 1971. But it's also notable that here in Adelaide, there's a number of women, older women, who were concerned about the problems of access to healthcare for Aboriginal people here. And that's around about the same time, 1971. Gladys Elfink and other women worked with a local GP to open up a shopfront health service in Wakefield Street in Adelaide, which subsequently morphed into what is now Nunkawurrungyunti, the Aboriginal Community Controlled Health Service in Adelaide. And this idea, this sort of it was an idea whose time had come, and so Aboriginal Community Controlled Health Services started being developed throughout Australia, in capital cities, regional centres. In Alice Springs in 1974, the Central Australian Aboriginal Congress started. I went to work there in 1977. In its early days as a very vibrant community-controlled organisation. And it was just at that time when I started that there were the first remote communities with Aboriginal community-controlled health services who were getting funded. So I became involved in the Aboriginal community-controlled the Aboriginal Community-Controlled Health Service movement in remote parts of Central Australia from quite an early stage. But there are now about 150 ACCHOs across Australia. So these organisations are based in a community or a group of related communities with a locally elected board that oversees the activities of the organisation, and they employ their own staff, Aboriginal and non-Aboriginal, to provide appropriate healthcare for their community. Right from an early stage, there was a national peak body developed to represent the interests of Aboriginal community-controlled health services. It was originally called NAHO, and then later on it morphed into NACCHO, the National Aboriginal and Islander Health Organisation originally, and then the National Aboriginal Community Controlled Health Organisation. So NACCHO is currently the peak organisation for the Aboriginal Community Controlled Health Organisations across Australia, but it's important to recognise that the Aboriginal Community Controlled Health Organisations are not subservient to their national body. It's really the other way around. Given the ethos of community control, NACCHO takes its direction from the community-controlled health organisations across Australia. There are also state and territory affiliates of Aboriginal community-controlled health, what are called state and territory affiliates, but effectively state and territory peak bodies for the Aboriginal community-controlled health services in each state and territory. And in South Australia, that is the Aboriginal Health Council of South Australia, or ACCHO, where Michael and I have both worked. So the source of the strengths of ACCHOs, I think of it as consisting of two components, both of which give strength to this social movement. The first is that ACCHOs are Aboriginal organisations. There are other Aboriginal organisations as well as ACCHOs. There are legal services, there are housing services, there are art centres and so on, just community organisations. But as Aboriginal organisations, ACCHOs are agents of self-determination, and I'll delve into that a little. But also the other component of that gives strength to the ACCHO movement is the particular model of healthcare that has developed within ACCHOs of comprehensive primary healthcare, and I will delve into that a little also.
David, did you have slides to show? Sorry. No, you didn't.
Oh,
they're not showing. They're not
oh.
showing. And I'm sorry.
I'm sorry. Yes,
I thought
no,
I kept
thanks.
waiting, and the people are just asking on the questions.
Yeah,
so.
yeah. Sorry, I thought I had shared it, but maybe not. Let me just get back in. I'm out of. Oh my God, I'm out of the meeting.
No, you're in the meeting. You're in the meeting. It's fine. I just think you just need to share screen.
I can't see it myself. Oh, here I am. Sorry. I'm very sorry.
No, don't worry. I mean, I know it happens, and if you're using another screen, you can't see what's on the Zoom screen. So that's perfect.
Here we are.
That's it. Perfect.
Yeah, that's much better. I'm sorry. I did have slides for the earlier ones, but we'll keep going from here. So ACCHOs as Aboriginal organisations. Firstly, ACCHOs are, as I said, they're a social movement. It is important to recognise this history, that it is a movement that emerged from Aboriginal communities themselves, and as such, they're an expression of Aboriginal civil society, a manifestation of self-determination and agency of Aboriginal communities taking control of their own affairs. They're also an example of subsidiarity, the concept that in general, if decision can be made as close as possible to the people who are affected by those decisions, they're more likely to be appropriate decisions. So Aboriginal organisations are local organisations, and so they're able to be aware of what the issues are within their organisation and develop programs to be appropriate for their particular community. I think Aboriginal community-controlled health services are probably the best example of subsidiarity within the healthcare system generally within Australia. They also, being Aboriginal organisations, they are culturally appropriate. They provide cultural security for the people who access that organisation, and Michael will develop that aspect a little bit further later in our presentation. For all these reasons, and for the fact that they are local organisations, and within the Aboriginal community itself, they are able to provide better access to essential services such as health in the case of Aboriginal community-controlled health organisations. And Aboriginal organisations are an important source of employment and training for Aboriginal people. And again, Michael will build on that a bit, but I would also make the comment as a non-Aboriginal person that one of the aspects of Aboriginal community-controlled health organisations that I've always found very important is that they provide a way of non-Aboriginal people who want to make a contribution towards the improvement of Aboriginal health. It provides a context in which people like myself can work, where we are accountable to the Aboriginal community, to the Aboriginal leadership. And that just makes it a more appropriate way for non-Aboriginal people to work within, I think, the settler colonial context. So that's ACCHOs as Aboriginal organisations. In terms of ACCHOs as providers of primary health care, they have developed a model right from the beginning. They had a model of comprehensive primary health care, of ensuring that a range of services are provided, and in a context where you have multidisciplinary teams of Aboriginal and non-Aboriginal people working together. This idea of community health centres. It was actually that concept was quite popular at the time that ACCHOs emerged in the 60s and 70s. And in fact, there was in the early 70s a national community health program in Australia that came in with the Whitlam government. And there are a number of community health centres established across Australia, but most of these have not been able to retain, for various reasons, have not continued or have not been able to retain that sort of community health approach to the way primary health care is provided. But the community health concept has really survived probably better than any other component of the Australian healthcare system within the Aboriginal community-controlled health organisational sector. They provide a focus on prevention, early intervention, and the social and cultural determinants of health, and they do provide effective health care. There's good evidence to support this, and one reference to this was the systematic review that Megan Campbell and her colleagues did back in 2017, which looked at all the literature and was able to show that the community-controlled health sector provides best practice in primary health care and definitely improves access for Aboriginal people to health care. So, given this whole story of the Aboriginal community-controlled health service movement, an Indigenous movement itself, which has been able to develop a particular model of primary health care within an Aboriginal organisational context, it really is something I think most people would agree is something which should be celebrated. But as I'll go on to just briefly cover, it hasn't always received the support that it deserves. So the government response to ACCHOs, I think of it in two different eras, really. When they first emerged in the early 1970s, from a fairly early stage, there was Commonwealth government support for this movement, particularly with the election of the Whitlam government in 1972. And the Whitlam government introduced became a national policy of self-determination for Aboriginal affairs across the country, replacing the old policy of assimilation. And Commonwealth government began to provide financial support for the emerging Aboriginal community-controlled health services. Initially, there was quite significant resistance from state and territory governments who saw healthcare as being their responsibility. They resented the Commonwealth government becoming involved in primary healthcare within their jurisdictions, and there tended to be perception within state and territory health governments that that they had the expertise in healthcare, and Aboriginal communities would not have the expertise required. And so they tended to push back initially against the Aboriginal community-controlled health services, but with the Commonwealth Government support and the resilience of the communities themselves, the Aboriginal community-controlled health services persisted, and over time, state and territory governments became more supportive and appreciative of the role that Aboriginal community-controlled health services played in providing primary health care within their jurisdictions, and in fact, reducing costs because of the reduced need for hospitalisation because of the effective primary health care that was being made available. The next era was a bit of a shift it was a significant shift really in policy from the late 1990s, which was sort of really the end of the self-determination era, and what might be called the neo-assimilationist era, or perhaps the neoliberal era, with the increasing hegemony of the neoliberal economics of free markets, privatisations, deregulation, and small government. And I put small government in brackets because, in general, small government applied to businesses and corporations, but within the sort of neoliberal ideology, there became increasing centralised and paternalistic control within the Commonwealth Government over Aboriginal affairs, with much less support for self-determination and community control. And in fact, the narrative that was being used by, particularly during the Howard government, was that self-determination has failed, and that was exemplified by the closure of ACCHO. So as part of this sort of process, increasingly, the term that was being used was mainstreaming, that services such as health services should be, there shouldn't be specific services available for Aboriginal people, that Aboriginal people should use the mainstream services that everybody else used. So there was funding diverted away from Aboriginal community-controlled health services to other primary health care services, and particularly fee-for-service general practice, which was not well set up to provide care to Aboriginal people, and was often not in the areas where Aboriginal people had good access to primary health care. But it also meant that the funding for Aboriginal health care, instead of going directly to Aboriginal organisations, often went to or through non-Aboriginal organisations. So increasingly non-Aboriginal organisations were being funded to either provide Aboriginal health care, or as the fund holders for buckets of money which Aboriginal community-controlled health services could bid for, but often were in the situation where they were bidding against other non-Aboriginal organisations who were better resourced to develop submissions for the funding that was available. And at the same time that all this was happening, there was this change in the ethos of the public service into what's sometimes called the new public management, or neoliberal public management, or bureaucratic managerialism, where there was, instead of the public service being in a situation where it could provide frank and fearless advice to government and to provide a service to the public, as public servants by their name you would expect they would do, they became much more politicised and saw their role, increasingly they were encouraged to see their role as providing protection for their minister. And while this was happening, the public service was being downsized, and increasingly the role of the public service was being outsourced to other organisations, to non-Aboriginal organisations, such as the Big Four accounting agencies, and we've certainly seen recently how effective and ethical that has been. So this really had a significant impact on the way Aboriginal community controlled health services were able to function within the Australian health system, but their resilience has persisted, and they have continued. This neo-assimilationist era, as I've called it, really started with the Howard era, but it has persisted through other governments, Labor and coalition governments since then. Where it is going from here is hard to say. Certainly, I don't think it has changed yet, but we might be moving into a new era, and one would certainly hope so. But I'll leave it at that for now, and I'll hand it over to Michael to continue with his part of the talk.
And can I just introduce Michael before he speaks? Michael is a Kodkafa man who joined at the University of Adelaide about a year ago, and prior to that he's held senior positions in the Aboriginal community controlled health sector, including as the manager of public health and primary health care at the Aboriginal Health Council of South Australia, ACCHO, where he was looking at a lot of statewide programs and different portfolio areas. And I think you also have experience with Ngukurrarran Yunti, which is the Aboriginal controlled organisation that covers most of the Adelaide metropolitan area. And he's currently also co-chair of the Aboriginal Research Ethics Committee, ARAC. So over to you, Michael.
Got a PowerPoint here too, which I'll bring up. Okay. Can that see that, friend? That's up?
Yes.
Yeah, right.
Yeah, it's
okay.
lovely. Thank you.
Yeah. So yeah, I just thought today I'd sort of look at, obviously with David covering a lot of the issues around sort of the Aboriginal community controlled governance and models of comprehensive primary healthcare. I thought I'd also look at just, reminding everyone about some of the drivers of health inequity. And then my reflection working in the peak body, looking at workforce, research ethics, and the ACCHO COVID-19 response. Those are all really good examples of how the ACCHO sector contributes to health equity. And then finish with some commentary on a bit of challenges and opportunities moving forward. So yeah, I think this is a really good conceptual model that was introduced to me by some of my colleagues at the Yatchapurna Indigenous Health Unit here within the university. And I wanted to show this because some work that I was reading out of the Stretton Institute of Health and Welfare, one of their recent reports made some estimates around the differences in health equity between Aboriginal and non-Indigenous Australians. They looked at having 30% of that gap being associated with social determinants of health, that we can see there on education, employment, income, housing, 20% in relation to more around health behaviours, diet, nutrition, smoking, and up to 50% was in relation to the impacts of colonisation. So that ongoing intergenerational trauma from separation of land, family, community and culture. So I think this is really important for us to always keep this in mind when we shape our narratives and how we think about health equity. I think it's also important within health as well to acknowledge, obviously within that, the biomedical model and approaches for health, there's been great strides in treating of diseases and diagnosis. However, in terms of addressing health equity across populations, there's clearly going to need to be, when we think about those percentages I provided just before, a lot more work outside of just the clinic space. But I think what we can say, and what I often reflect with the ACCHO movement, is that there is a strong focus on connection to land, family, community and culture through the actual movement itself. There is an acknowledgement through intersectoral partnerships and collaborations working with housing, justice, education, of the importance of those social determinants. So I think that through the community voice that comes into the ACCHO sector, it's a really powerful way of impacting social determinants through acknowledging the importance of community, family, land and culture on health. And that's the way forward for the ACCHO sector in relation to how it addresses, I guess, more of a a model of health which is far larger than just strictly a biomedical approach. And you can see this as well. I think it's always good to go back to the foundation of how ACCHOs define health, and a definition of Aboriginal health, which it means not just the physical well-being of the individual, but refers to the social, emotional, and cultural well-being of a whole community, in which the individual is able to achieve their full potential as a human being, thereby bring about the total well-being of their community. It's a whole of life view and includes the cyclical concept of life, death, life. And I think this again adds just more weight to that argument. You can see that even from the position of how health is defined, that it's actually taking into consideration the social and cultural components. And it's not just thinking about individuals, but it's thinking about a whole community. But it also then can recognise the fact that across all the nation groups of Australia and within individuals, there is a lot of diversity within Aboriginal culture. Working at the Aboriginal Health Council, the motto was our health, our choice, our way. And so I think that pretty well sums up the importance of having Aboriginal people being able to have a voice in the direction of health for themselves and community. Workforce was an area that I worked in. I was a part of a workforce team in the Aboriginal Health Council for several years. I think another way that the ACCHO health sector contributes to health equity is through its workforce development. This is both in actually what Scrim referenced, that it's a great place for non-Aboriginal health professionals to work and learn. It also is great for cultural learning for Aboriginal people as well, and I definitely am someone who's benefited from my time working in the sector. But I think also the ACCHO sector are great educators. Through myself, I did a Certificate 3 in Aboriginal and Torres Strait Islander primary healthcare. Through ACCHO, got a Certificate 4 in training and assessment through Ngunnawal University. And the model of education and learning is fantastic, because you actually learn so much by doing. So it's great. In my new role now as a lecturer, moving into an academic space, I'm more conscious of thinking about pedagogy and how are we teaching and learning. And I think that within the Aboriginal community control sector, so much of that just comes as second nature for the way you work. I know one thing that I've loved about my time in the sector, as well as being this idea about intergenerational learning, which again is a really important cultural principle. I'm probably at a stage in my career now where I've had people who were senior when I started working in Aboriginal health and mentored and looked after me, and now I get the opportunity with their children coming through, and I can actually provide some guidance and mentorship for those young people coming through now, which is, it's a really beautiful thing within the Aboriginal community control sector, and I think that's worth celebrating. It would be remiss not to mention the Aboriginal and Torres Strait Islander health worker workforce. Don't have obviously a lot of time today to go into details about the importance and the history of this workforce, but there's the National Association, which I've just referenced there, which is a great source for information. I mean, there's so much evidence which shows the strengths and benefits that Aboriginal health workers and practitioners bring to not just Aboriginal community control organisations, but working in state government, working in hospitals in relation to improving access for our people in terms of primary healthcare, but also within hospital settings. And I think it's just worth pointing out that as a workforce, it's not only the fantastic cultural knowledge and ability to connect with your community and in terms of that navigation aspect, it's also the fact that the workforce is trained in that model that David referenced in relation to comprehensive primary healthcare. So there's a really strong foundation. And yeah, that other point is that talking about when we looked at the social determinants of health and the importance that the ACCHO sector is one of the largest employers of Aboriginal people in Australia. Another area that I've been involved in is in research ethics, and I think it's another way that the Aboriginal community control sector has shown great leadership and has also shown great initiative. And when we think about research, there hasn't been a great history going back in terms of there's been a lot of harmful practices from researchers working with Aboriginal communities. So within the work of the Aboriginal Health Research Ethics Committee. It's a part of that history that David was referring to. This committee's been around since 1986, so approaching 40 years, which I think is amazing. And it's a great privilege for myself now to be a part of that committee and carry on that legacy of this work. The work that we look at doing as a committee, it's like any ethics committee, but there are certain elements where we do have a stronger cultural focus. We spend a lot of time thinking about, okay, is this actually going to be a benefit for the community? Looking at the cultural appropriateness. So this is how have researchers form partnerships with the Aboriginal community? Are there Aboriginal people involved on the research team? And certainly this is the area that we find that the best way for non-Aboriginal researchers to be working in this space is to partner with Aboriginal people. The ACCHO sector are a great example. If you can partner with Aboriginal community control health organisations, no one else is going to understand your community, their communities better, and in relation to engaging with participants, making sure you have the correct cultural protocols. But we don't just look at the sort of Aboriginal cultural perspective. We also look at this idea around, poor science is bad ethics. And I think from our learnings working in the Aboriginal health sector, that we're really conscious that if you have research that goes, research that gets published, which isn't well designed, you're going to get findings which can be incorrect, and then that can lead to poor policy development and a waste of resources down the track. And it also can lead to, if it's a sensitive issue, it can cause a lot of distress if it gets picked up by the media. One area as well, which probably doesn't get spoken about as much, is that, obviously take into consideration the amount of research that's happened in Aboriginal communities over the years, is that we want to make sure that research that does happen is of the highest quality, because we can have 4 or 5 different research groups coming in and to work in communities. And it can be similar topics, so you can understand then where people get a little bit of fatigue. So if there isn't that importance of actually seeing benefit arising from the research. Sector capacity building is another important area we look at. We're very conscious of the fact that a lot of ACCHOs want to get more involved in research, but again, there are constraints just based upon resources. But this is something which I've seen from my time working in Aboriginal health research ethics area, that we are seeing more ACCHOs getting involved in research, and that's, researchers engaging and including members of ACCHOs as authors on papers, and so it's great to see. We're also doing some work. This is through when I was employed at ACCHO, but I've sort of maintained involvement in projects working with SAMRI in relation to doing some work within the sector and surveys to determine where do the researchers need and feel like there's capacity building need for working with Aboriginal people in terms of improving the research output. Again, in terms of ACCHO leadership, I think the COVID-19 response was a really amazing example of what Aboriginal communities control movement can do. So look, it was, as everyone's aware, it did represent a significant threat, a lot of distress at the time for Aboriginal people. But I think that the response from Aboriginal communities in the ACCHO sector was outstanding, and it's been widely recognised. And the community was really on the front foot. So we saw this in the way that communities, just took control. Some of that was in relation to starting to automatically start putting messages out there through networks, through Facebook. It was through communities looking at issues around food security and taking matters into their own hands. It was the way that within this campaign we had ACCHOs come very strong, very quick, and work with governments around establishing national committees, and they were able to negotiate funding to come through directly to members on the ground. So we had the ACCHOs and we had the state affiliates with buckets of money to develop resources and get the message out to communities. And I think in terms of success, I think within the first 12 months, we didn't have a single fatality within our communities. And I think even now, ACCHO have just put out a statement recently, which have shown that there was estimates up to, 2,000, I think 250 projected loss of life. But, it's very sad that they said 250 people had passed away. but that's still a significant improvement on what was estimated. And I think it just goes to show, you know, how great Aboriginal community control sector in the community works and steps up when there's the correct response and adequate resourcing from government. Challenges, yeah, so look, funding, there's lots of different challenges obviously within the work staff turnover being a big one, I think, within ACCHOs, but funding's a major issue, and it's a bit of a theme of what we're talking about today. So often funding's less than need, particular areas like, you know, capital infrastructure in particular. Scrim referenced this one, competitive tendering. It's great that there's more organisations now who are more conscious about their responsibilities for providing care for Aboriginal people amongst a lot of NGOs and different consultancy agencies, but it can also then dilute some of the funding, and it becomes problematic when you have organisations who apply for funding, get the money, and then come to the Aboriginal organisations and say, so can you help us to engage with community and run our program? It really needs to be the other way around, that you come and engage with the ACCHO first, build that partnership, form the relationship, and then be like, how can we work together? Yeah, excessive reporting requirements and fragmented funding. Probably the best place is the overburden report. I'm conscious of my time now, so we'll skim over some of these points. Again, in the peak body, my experience was around a lot of issues with short-term funding, body part funding. You know, we espouse these models about holistic care and how we want to operate in the model within ACCHO sector, but we're quite constrained still when funding is really aligned and KPIs are really aligned to specific outputs around the body part or the disease you're working on, when that might not be the core focus of the community at that time. But opportunities, look, there's a lot of great opportunities on the horizon as well. I think the work of different Aboriginal community control organisations coming together as a collective voice is very important. Through SACON, a lot more talk now and research in the area of data sovereignty, and how as a sector we can better harness data and control the narrative, in particular in the areas around research, quality improvement and advocacy. And I think in Aboriginal health research, seeing more ACCHOs get more resources and involvement, and the sector, better engaging with ACCHOs. So in summary, there's a long and important history in the development of the Aboriginal community control health sector. ACCHOs promote health equity through a multitude of ways: the governance structure, through the model of care, workforce, research and ethics, and examples of community leadership. And look, while there are challenges, an appropriately resourced Aboriginal community control health sector is well placed towards driving achievements in the area of health equity. Thank you.
That's great. Thank you, Michael. It is so good to hear such a positive story about Aboriginal health. And I think it also shows why, you know, having a voice to Parliament is so important as well. I think that when I think David spoke about the term subsidiarity, which is a horrible word, but it's a really good principle that if you bring decision making down to the people who are affected, then it's much more likely to be effective. And I think you've both shown how important that was. And David, you also put it in the broader kind of political economy of Australia and the onslaught of neoliberalism, if you like. And I thought both of you stressed about workforce development, which is really important. And I think, Michael, you particularly made the point that it's the one sector where people can really get experience of comprehensive primary health care. There's not many examples in the country. I think some of the Victorian generic community health centres are a bit similar, but other than that, while we used to have great community health centres in South Australia, they've basically been closed down as well. So it is a really important training space, I think, for people. And also, Michael, I loved your summing it up, our choice, our health, our way. That's just such a nice way of saying, you know, why community control works so easily. So I'd like to open it for questions. I think people can put it into the Q&A, or I think you can put it into chat, or raise your hand. I think whatever way you'd feel most comfortable to do that. I just wonder, Michael, you had to go fairly fast at the end, but could you tell us a bit about SACON? I think that's the acronym. that's a sort of a peak organisation for Aboriginal community control. Could you tell us what organisations are involved in that and the sorts of advocacy they've been doing? I personally don't know much about it, and I suspect it might be good for other people to hear about that too.
Sure. Look, I'm not directly involved myself in SACON, but I think that it's, from my understanding from the work I have seen, you have a number of different Aboriginal peak bodies, such as Aboriginal Health Council, but you also have the Aboriginal Legal Rights Movement, you have Aboriginal Family Support Services, Aboriginal Drug and Alcohol Council, Aboriginal Sobriety Group. You have a number of different agencies working, and then you have individual ACCHOs that are also involved in that. So I think that the key message for me in terms of the work of SACON is that it's actually broadening the scope of, when we had that slide up looking at the importance around social determinants, it's actually broadening the scope so we have Aboriginal community control, because it's not this idea of what we said about having communities determine and have the voice around what's going to work for them and their communities isn't just within health, it's also across all of those sectors.
Yeah, that's great. Thanks, Michael.
At a national level, it's called the Coalition of Peaks. Exists. It's called the Coalition of Peaks, which is the coalition of all the peak bodies for the Aboriginal organisational sector across Australia, including the Aboriginal community controlled health sector. So, it's there at the national level as well at the state and territory level.
That's fantastic. Yeah. Richard Porter's asked a question. Richard, I've done it so you can ask your question if you like.
Yes, thank you, Fran. I've got to try and remember the question, sorry. So thank you, David and Michael, for such informative talks, so many lessons that we can learn there. David, you mentioned that the ethos of the ACCHOs has been able to be sort of maintained whilst you mentioned that community health centres, both in South Australia and Victoria, have either closed, or in Victoria we've seen community health centres merge, and so therefore the local communities have less say in what actually occurs in those community health centres. So I was sort of wondering, why do you think ACCHOs have been able to survive despite community health centres, as I mentioned, in South Australia closing? And then also, if there's ongoing pressure for the ACCHOs to merge because of the issues around funding that you mentioned, as a result of neo-liberalisation of funding in health.
Why has that community health concept survived within the Aboriginal community controlled health sector? I guess because they have been able to retain control over the way they provide health care to a large extent, although there are the kind of pressures that Michael was referring to with the selective primary healthcare approach of sort of buckets of money which are specific for specific areas rather than for comprehensive primary healthcare. But the concept has been able to be retained. I think the community health centres in South Australia, for example, were sort of gradually absorbed back into the health department, and so it was decisions being made in the health department about how healthcare would be provided within the Aboriginal community controlled health sector. To a large extent, despite the pressures, those decisions have been able to be retained within the Aboriginal community organisational sector, so that they have been able to continue to provide that kind of care. Your second question was the pressure to merge.
Yeah.
Certainly there has been some merger of Aboriginal community controlled health services, but not a lot. Where it has happened, it's been where there has been cultural links between different communities, and it has made sense for communities to work together. I'm involved at the moment in Central Australia with the merger of two different health services that were originally one health service, and then two different communities. They separated, and now they're coming back together because they are really very, very related to each other. So that has happened. There's also been some sort of alliances of health service. So in South Australia, Yalata and Oak Valley each have their own community-controlled health services, and just across the border in Western Australia, Junjunjara has Spinifex Health Service, its own health service. They retain autonomy for each of those three health services, but they have an alliance called the Kakarara Willarara Health Alliance, the East-West Health Alliance, where they work together to pool resources where necessary, given that they're three small Aboriginal community-controlled health services, to be able to pool resources to get specialist visits and so on. So I think in general, although there has been some pressure to merge, I think Aboriginal community-controlled health services have tended to ensure that they do continue to be in the kind of organisations that are able to make decisions at the local level for the local communities, whether it's one community or a group of related communities.
Thanks, David. Did you want to add anything, Michael, or has?
Oh, I'll just echo, David's comments and support that response. Yeah, and I think there's just our Aboriginal leaders and elders, stand up when things are under threat, and there's been a strong voice always to support these systems and structures through the Aboriginal community control health sector and through the peak body. So there's a lot of advocacy which happens, which is really important to maintain the continued investment in this approach. And also, we are seeing more of the regional partnership approaches, which I think is really positive in terms of when you can get different ACCHOs working together to either support, it could be administrative things within an organisation for it saving money in terms of, your HR, finance, things like that. But it can also be partnership approaches for applying for grants as well, because as we know, there isn't always capacity within one ACCHO, particularly if it's a smaller ACCHO, to be able to actually invest in positions to be writing grants and things like that around opportunities. So if you can do that as a collective, you've got a better chance of bringing in more resources to the organisation.
That's fantastic. Well, another question is, how do you find out where they are? And just while we're waiting, I just say that people should just look at the NACCHO page. So you can see here a map of Australia, and it can tell you, you can find out exactly, you put a suburb or town in, and you can find out where that ACCHO is. So NACCHO is a great resource, and just as the equivalent to NACCHO in South Australia, for people who don't know, is ACCCA, which is the Aboriginal Health Council of South Australia. So that's a peak body in South Australia, and each state has that kind of peak body. So if you head to NACCHO, if you don't know much about the community controlled health centres, it will give you quite a lot of information, I think. So I'll just stop sharing and come back. We've had another comment thanking you both very much, saying how informative it was, and I agree with that. And let me see, we've got another question. Some researchers don't know the best ways to approach ACCHOs and worry about overburdening. Is there a set of guidelines for appropriate engagement? Well, I know partly there's NH and MRC guidelines, but Michael, would you like to address that from your experience on the ethics?
Yeah. Wadley Perinder through summary. We've also got this Australian Aboriginal Research Accord, which is a great document. ACCCA is also a great resource. I think it comes down to you just need to spend the time to know that if you've got an idea for research, that you need to actually think about, if you want to do research with Aboriginal communities, you do need to put time initially into building relationships and building those connections. And that's not going to be about one particular research project. You need to actually spend some time, go and introduce yourself, you know, share what skills you got, what opportunities there are. And then once you've built that connection over time, and it's actually saying, well, what does the community need in terms of research? But I think in terms of a sector response to that, I think that's something which we can probably look at coming up with different ways and more investment through, you know, whether it's regional partnerships or it's through the work of your Wadley Paringas or it's through ACCHO, in terms of helping to create roadmaps, helping to create, you know, priority areas for research from communities, and that way that it sort of takes away some of the time burdens. But yeah, it comes down to building relationships first and foremost.
Great, yeah, thanks, Michael. And certainly my experience of Aboriginal health research is that the relationality of it is absolutely crucial. It's not something you could decide 1 year you're just going to do. It needs to take time. Someone's also asked here, Neil Macmillan, that there are areas in SA that don't have an ACCHO, and he points out the Riverland and Berry. So what responsibilities do the local health networks have for health engagement in the context of self-determination? Would either of you like to tackle that one?
Michael, perhaps start with you.
Yeah, it's a good point. I think there's been different structures historically. There used to be health advisory committees in those regions, which were also connected in having input into ACCHO's sort of governance structure. But I think that, yeah, it's super important still for those communities to have a voice. I think there is conversation and work. I know there was at one stage around developing further, and I think the more we can expand and develop the Aboriginal community control health sector to create new services done in a sustainable way, which works with the communities, the pace at which the community wants to work, I think that's yeah, only going to be a good thing.
Yeah, that's great.
Yeah, so I would agree. And I mean, there are always some kind of Aboriginal organisations available. So even if they're not Aboriginal community controlled health services, there are representative structures for Aboriginal communities which you should be able to engage with.
Yeah, that's a good point. So thank you both for that. The final question's from Sam Battens, who's saying that when you do research and evaluation, it's really hard to get ethics in the area of education and child protection. And that has the potential to impact on the AREC. So she suggested government should come up with solutions. I don't know if you've come up against that, Michael. If something isn't directly health related, do they ever come to AREC instead? Or?
Yeah, we're quite conscious that we can really only look at what's in scope for our review. So yeah, there are certain topics like this. You know, if something's particularly sensitive, we still may have some scope to provide some feedback or provide some advice on where researchers can go. But yeah, we are quite conscious that we're really focusing on health related research that we're under our guidelines here.
Well, that's fantastic, and I really just want to thank you both. I thought, Michael, it's really important that you pointed out how well ACCHOs had worked with Aboriginal communities during the pandemic. It really just, I know that even with things from Congress like contact tracing, ACCHOs was so much better at being able to do that than other parts of the health system. So that's really highlighted something very contemporary. And I think between you, you've also given the history of ACCHOs. You've shown us where they came from, what terrible headwinds they faced from different governments. But the really good news is that they sort of come out of that very strongly. And there is now, I think, a federal coalition of peaks that's really able to argue for a lot of the importance of community control and what a difference it does make to health. So thanks to you both very much. I really appreciated both of you, and I think from the comments the audience did as well. So thanks very much, and we'll email you all with details of our next HELLO seminar, which will be later in the year. Thanks very much. Bye-bye.